Great.
Oh, yeah, great. Shall I start then?
Yeah, go for it.
Oh, brilliant. Okay, thank you. Well, I have got a little PowerPoint. Oh, can I be made host so I can share my screen?
You're muted, Danny.
Excellent, thank you. Okay, so lovely to see you all. Thank you so much for coming along. So who am I? Anna Harrington, just like many of you possibly. I'm an occupational health advisor, the usual specialist community public health nurse. Been in the business for about 19 years. I set up my business in 2019 called WIB Limited. I'd call myself a specialist occupational health provider because I only do the case management work, although I say only, I do also some organisational wellbeing aspects as well, but I don't do any of the health surveillance work. I'm also a specialist because I work with independent human resource people and small businesses. And I'm very much enjoying what I'm doing in that field. So Daddy asked me if I can come along and do something about long COVID. We discussed, well, what would you like me to do? And came up with the idea of maybe doing a case study. Could be interesting. I'm a member of the Society of Occupational Medicine, and I'm part of their, along with Colette, who's on here. Hi, Colette. I'm part of their multidisciplinary task force group for long COVID, which is a brilliant group to be part of, hearing about sort of the pressures and also what's happening within the NHS England, and what's trying to be done with regards to long COVID clinics. Okay, so very much today is about shared learning. So I don't think anybody here can class themselves as an expert with regards to long COVID. This is all about support. I've got a case study, which I'll bring up now. And this always happens. Oh, there we are. Sorry, this always happens, meaning that I was clicking on and my slides weren't actually moving on. I have actually popped this case study into the chat box as well, so that it was in case we were having breakout rooms and we weren't going to be expected to be able to see this slide if you're in a breakout room. Okay, so this case is actually more or less one that I've dealt with. So an employee who was is a design and technology teacher acquired COVID about 6 months ago, didn't require hospitalization. In terms of their work, they are, in addition to being design and technology teacher, they're also head of year 8 and they are full-time. The reason that I thought this might be a good case study is because that job role incorporates sort of physical, cognitive and emotional demands. So I thought aspects of this are going to be applicable to many job roles. So this employee is exhibiting shortness of breath, they're exhibiting brain fog, fatigue, poor sleep. They have anxiety, but that's a long-term problem. So they don't feel that the anxiety is triggered by the long COVID. They are not on any treatments at all, and they have tried to consult their GP, but they've been dismissed by their GP, being told they just need to get on with things. They are off sick from work, and the individual employee has got financial pressures to return back into work. They're a single parent of 2 children. They're aged 7 to 8. They're also a very dedicated employee, so work means an awful lot to them. They get a lot of sense of satisfaction, fulfillment, social engagement from work. Okay, so the questions that I've posed in terms of discussion points for the case study, which I thought we could do together, are: how would you assess the job demands? So how would you question the individual employee, or what other information would you want to be gathering from other sources that would give you an indication of what those job demands are, both in terms of sort of quantity, so the different type of activities that they're doing, and also the specific activities. What would you use in terms of any screening tools or questionnaires in terms of their health and their ill health and their functional capacity? I'm really interested to talk with you, about that, about use of different types of tools for that. What indicators do you use that suggests that a return to work would be imminent, you know what I mean, can't say that word, it's going to be very soon and is appropriate as well? What adjustments would you suggest both to the employer and the employee in order to ensure that that return to work is as successful as possible? So success meaning that they're able to perform up to their best possible abilities, and also that they're going to be consistent in terms of attendance and performance levels. And then lastly, what advice would you give the employee with regards to signposting? Okay, so do you want to come off chat and shall we sort of talk about maybe the case study questions, take them one by one, talk about them together? Does that sound okay? Excellent. All right, so let's start off with the job demands. So what would you look at with regards to job demands, and how do you go about, what sort of questions would you be asking, and what sort of information, the resources would you be wanting to gather in order to give you that clarity as best you can about what the job demands are? Fire away, anybody.
I think for these types of cases, like having a good referral form, so getting from the referring manager, a snapshot of what their job demands are, but also trying to get the job description, and then of course the interview with the staff member as well. So just gathering that information with your questioning. But I do find having the job description quite helpful. Depends how good the job description is.
Yeah.
But also from the perspective of the manager, just what they feel the demands of the work is.
Yeah.
Use that on their forms. But
yeah. Anybody else got any suggestions?
Just following on from Claire's, really just kind of like the fundamentals, so working hours, and particularly as they're a teacher, what actually are their timetabled working hours and how much actual extra time are they actually doing, particularly as they are a year ahead of year as well. Actually, when are they not working might be a better question to ask. And I think with that as well, and it's something you touched upon in when you were describing it. If there's, yes, we'd ask them to use their job task, and D&T as well. So design technology, they're going to be it's a very practical subject. So they are going to be using machinery. There is a lot of show and tell and checking in with the students as well. There's a lot of project work, so there's going to be a lot of like checking in the whole time. So just finding out the bits and pieces about that. But it's as you touched about, it's the head of year 8 and everything else. It's the emotional aspect. So are they able to put into either percentages or ratios, how much of their time is emotional, how much is mental, and how much is physical, because I think that really does give you a good idea about demands. And with that, staff meetings, parent meetings, all those kind of things. So it would be quite detailed, but I think we've discussed this before, the more detail you can get with these long COVID patients, the better, particularly when it comes to that return to work.
Yes, absolutely. Very similar. I use obviously the job description, but often I find the job description doesn't give me the actual sort of real demands. They're just sort of top line statements and don't actually tell me about the physical, cognitive and emotional elements of the role. So yeah, asking a lot more actually of the individual employee as to exactly as you say, Colette. That's what I do. I think, can you estimate the percentage of time, for instance, that you're doing attention to detail stuff, that you're doing problem solving, data analysis? Well, as a teacher, I'm making the assumption that you're using your voice the vast majority of the time, and we've got somebody here with shortness of breath. But also about managing multiple people, so not young people, but exactly like you said there, Colette. Also, head of year is going to be managing the team of that department and the parents and the senior management team. Anybody else got any comments or suggestions with regards to assessing the job role itself? The other aspects that I look at as well is about and I've touched on it in the presentation of the case, which is about what does work mean to that person? From both perspectives of motivation. So either being motivated, too driven to return to work too early, or that lack of motivation influencing and creating barriers to return back into work. What about sort of things like the commute? Does anybody ask anything with regards to that? Colette's nodding. yeah. And Jenny, what sort of things do you ask, and what sort of judgments do you make according to the responses from the questions about commute?
I think you're right about definitely right about the motivation to return to work. I work in a police setting,
right?
So it's very different to this, obviously.
Yeah.
We are starting to see some cases, which is why I've kind of jumped in. I happened to see it whilst I was at lunch looking through my Facebook page, and I thought, oh, I'll jump into that.
Yeah.
So yeah, the demands of the job, and sort of whether there's any flexibility in, if it's long distances, do they have the ability to be able to carry out some function at home? Because particularly during COVID, some people may well have been given technology to be able to do work from home. So that might be something that's worth considering.
Yeah. Absolutely. And I think that as well, this early stage, when in my assessments, I do this job demand stuff as the first place that I start asking questions of, because already I'm starting to gauge from the employee as to what they perceive as going to be the issues with regards to returning back into work. Of course, I'm not yet linking it with the ill health and the symptoms and the functionality, but I'm starting already to get that picture really of what's going on. Okay.
I suppose another one with this is obviously the person's a single parent of two pretty young children. So again, it's not only they're embedded in school life, but is their family or other support with getting the youngsters to school, or so what limitations are there? So that would be really interesting to find out more as well.
Yeah, absolutely. Thank you for picking that up, Colette. Yes, it's looking at that whole person, isn't it? That sociological perspective of this individual's employee's environment. Yeah, fantastic.
I was going to say, Anna, along with
Yes.
the motivation to return to work, which is, you know, really, really important. What Colette and I have seen in our pathway is people's anxieties about where they think they caught COVID. And that has been in the workplace. The anxiety of them going back into the workplace has been quite a big barrier for quite a number of us. And even if it's like they thought they caught it in the supermarket, now they don't like to go to the supermarket. But I can imagine if, you know, more and more people we see that they think they caught it in the work environment, you know, it's becoming this barrier for them.
That's a great point. One I hadn't even considered, actually, and not encountered as yet. So yeah, thanks for flagging that one up. Okay, so from moving on to looking at assessing the individual's health and their functionality. So I'm really interested to know more about, you know, what tools do people use, screening tools do people use, and why do you use them when assessing people? I am very, sometimes I do and sometimes I don't, but I'll open the floor and tell me what sort of tools do you use?
I'll let Colette answer for us because we've got a whole raft that we use with everyone.
Yeah.
All right, this is when I have to try and remember them all. Right, okay, so we
sorry,
no, I'm going to start with the easy ones. We use the GAD and PHQ to get an idea of anxiety and depression. For the breathlessness, and again, with this is very chop and changey, but for the breathlessness, we're using the MRC scale because it's one question basically, and it gives you a score, a really clear score about, I think it's 4 and above would suggest refer on to respiratory specialist, whereas 3 and below means that you're okay to either self-manage or treat. So that's great for us because that gives us a great indication of, you know, whereas some of the others are a bit, you know, what does 6 out of 10 mean? You know, does that mean we're okay? But Lisa's score is very like, right, I need to go over there now. We modified, I'm going to get this one, I think this is the Yorkshire NHS Trust or the Leeds Trust. They've developed, I want to say, a C19 screening tool, and I know they're doing more around that.
Okay.
It's very long and it covers literally everything from fatigue to speech to swallowing to family help. So it's a very detailed outcome measure. I think they may have tweaked it since I last looked at it to make it a bit more usable, because again, some of it was a bit vague. So we use a modified version of that. We also use the fatigue assessment scale. As a first fatigue assessment. Many more we would go on. Oh gosh, what else do we use?
I've got them in front of me. I've got the MRC, the MRC, the modified C19 questionnaire, the PHQ9 and the GAD7 fatigue assessment scale, and then as required, the DePaul symptom questionnaire.
Yeah, so the DePaul symptom questionnaire is for those who you think might be having post-exertional malaise. So we've got this big, which I'm sure you will probably mention, Anna, we've got this big divide at the moment about fatigue and deconditioned patients. And the management of fatigue and being deconditioned is very, very different. If, you know, wearing my physiotherapy hat, if, you know, somebody mentioned that they were, you know, having difficulties getting up and downstairs, we'd probably think, oh, got to get their thigh muscles nice and strong or something like that. So we'd give them a muscle strengthening program, which for a fatigue patient is totally the wrong thing to do. So this whole symptom questionnaire helps you establish whether they do exhibit post-exertional malaise, which would be your chronic fatigue, fatigue ME type thing.
That's really fascinating, and certainly there's a lot of overlap there with tools that I sometimes use. I think we need to go back to purpose as well, because I think the tools that, and get me, you know, say I'm wrong, but that you're using is in relation to defining treatment pathways. Yeah, which of course is very different in terms of management referrals, where we're not going to be doing treatments.
Yeah, our pathway is basically, it starts with an assessment, so the 90-minute assessment and pre-assessment. Fill out this electronic, it's all automated, they fill in this, it takes them about 20 minutes to go through. So that when we get on the virtual call with them, we could go, actually these aren't a problem, because we've screened using the outcome measure, and then we're left with these are the indicators, as you say, that we can work on. Decide whether they're appropriate for the pathway or not, which is then the 6 sessions of
course. Yes. So in the management referral situation, what do people use in terms of screening tools? I do. Go on.
We basically use a symptom questionnaire, but ours is mainly looking about fitness tests for police and fire. So we use a symptom checker to make a decision as to whether they may or may not be fit to undertake the fitness test.
Yes, because you've got very strict criteria as well, haven't you, with regards to fitness? And I get
oh, sorry, I can't see everyone.
Oh,
can I? I was just. There's a long COVID group that I'm a member of on Facebook. A friend brought me into it, and these are health and social care workers who struggling with long COVID, and they're all talking about their occupational health experiences, and a common question that comes up is, I've been referred to occupational health, what are they going to ask me? Of course, people respond and they say, a couple of people came in and said, I'm usually asked how I feel on a scale of 1 to 10. And I thought, right, I don't ask people how they feel on a scale of 1 to 10. But with some of the employees that I'm seeing, because I am seeing them for reviews, either because they've relapsed or because the employer wants frequent reviews, sometimes, I think this simple scale, how are you feeling, 1 to 10, 1 to 5, I don't know, possibly could be quite useful. I hadn't thought of it before.
Just
all the other tools are really useful, but just how are you feeling at the moment? I'm 4 out of 10. Next time you see them, pretty good. I'm a 7, but understanding that 7 might not be sustained and it could easily drop back to a 2 or something. I just wonder if anyone else had thought of how are you feeling on a scale of 1 to 10.
We use we liaise quite closely with a psychotherapist, and that was exactly one of the questions we posed to him was, how do you measure people's mood? And 1 to 10 is a great scale. So Zirmal is 0 is neutral, and 10 is the worst I've ever felt. What we're also finding as well is the cognitive fog. And particularly as you go through the assessment, you can really see that they're struggling with concentration. And because we use like the Borg scale as well for breathlessness and rate of perceived exertion, which is a lot of numbers, different scales, nice colour chart, and you can see them really struggling. And then so we mix it up. So it's not all about numbers. Sometimes it will be, how do you feel, mild, moderate, severe? At least they've got a bit of a difference, because otherwise it can be so number heavy, you can actually see the fog literally come down in front of them. It's like, okay, let's just step back. So we have got a bit of a mix between numerical and word type rating, and sometimes I'll intermix it with whoever I'm seeing. It depends on how their cognitive brain fog is. But it's really, really helpful, and it's great for them, particularly when we are remeasuring, is because you can refer back to it. And today's a good day, but yesterday I was actually an 8, but today I'm actually more like a 4. So it's really helpful.
That's a great one. I only use that occasionally if I'm doing mental health assessments, pure mental health assessments. I'll just ask them, just give me, out of 1 to 10, where you think you're at in terms of your your mental health. And I think it is a really powerful and just quick and easy, because of course we're very, very time constrained in terms of management referrals, and they have to be very focused on what the manager is asking. So always I'm being cognizant of making sure that the questions that I'm asking are going to bring about purpose and relevance regarding to that report that of course is my outcome. Yes. What about activities of daily living? What do people do, and what sort of questions do you ask with regards to activities of daily living and getting, and you know, is that the way that you assess functionality, is through those sorts of questioning? I do. One of the, let me present, one of the real problems I have is being able to assess that cognitive function. And because I think, absolutely, I can understand, Colette, what you were describing there, the length of time required for that person to complete, you know, your assessments will reveal that cognitive function. But within the management referral, you know, how do you get an understanding of their cognitive function? You know, this teacher has said that they think that they have brain fog. Well, what does that mean? What does that mean to them, and what does that mean in terms of their job? How do you determine that?
So sometimes I've used like, if 100% was your normal, where are you now? So that must be a nice, easy way for them to say, if they were describing a particular task to me, and which they feel they have cognitive fog, it'd be like, okay, well, think pre-COVID, if that was 100%, where are you now? Then you can explore. It's a bit like motivational interviewing, isn't it? So then you explore the rest of it. What would bring you up to 100%? What would the differences be? So that's often quite a nice way of establishing activity. And often, again, when we're talking about the other symptoms, it would often be related to an activity. So I'll give you an example about when you're fatigued. We use the patient-specific functional scale, which remember, and that is again a score out of 10. So 10's your normal, 0 is I don't want to do this at all. So again, you get them to come up with the activity, and then they score it out of 10, and that's been shown to be reliable and valid. Reported outcome measures. That's a good one to use as well, because it can be anything, you know, it can be something cognitive, it could be something physical. They can choose. And we often make sure that there is, you know, at least one work activity in there. I ask about their driving as well, because if they feel confident to drive, then that gives me a suggestion that you know, where they're at in terms of their brain fog. So, and the details of that driving. So, for how long and what sort of circumstances? You know, we're talking about quiet roads. We're talking about busy in town driving, rush hour type driving. And things like, you know, watching films, are you reading anything? Do you keep having to go back and refresh yourself on what you've read? What about multitasking? Are you able to make a meal and chat to the kids at the same time? So those are the types of questions that I use to try and gain some detail on where they're at for brain fog and associated cognitive fatigue. So after how long can you manage that task?
I was thinking of driving as you were talking then. It's complicated, isn't it? If you're feeling like your brain fog's, you know, very significant and affecting your concentration and things, you're not going to go out in rush hour around the town, then on the motorway for half an hour. We're not going to do that, are you?
No, one would hope not.
You hope not,
because that is the other worry, isn't it? Is that actually their desire and motivation to drive and to get places blinds them to their brain fog, and you go, oh no. Yeah. Okay, fine. So I'm very aware of time. How long do you normally have for networking, or how long do you want for networking?
Because it's quite a small group, I think just keep going, Anne.
Fine. Okay.
It's a small group, so I think it's it's all good.
Brilliant. Excellent. All right. So the next question. Excellent. Thank you, Danny. So the next question, I wasn't sure whether you were still there because you were in the camera in the dark. So what indicators would you use that would suggest a return to work is appropriate? So what is it that the person might say to you that makes you start to think, okay, maybe they are?
I think often just them, like, they often know in themselves whether they're ready or whether they're not. You can tell quite quickly as you chat to them, even related to long COVID, back pain, knee pain, things we see, they will start, you can tell, deep inside whether they feel confident to go back or not, or whether they think they just absolutely are in no fit state to go back. So that often tells me, first of all, where we're roughly gauging. It's the ones where they're not sure but they want to, maybe they're going back a bit quick. It's those middle ground ones that is a bit more difficult, and you have to sort of drill down into it a bit more. But quite often they're starting to say, I've been doing X, Y, and Z, I've been getting myself ready, and they're making those behaviors and changes towards the goal of going back to work, versus someone who's napping all through the day, isn't doing their own self-care, not those sorts of things, and there's just no way that they think they could go back to work. It's at the other end of the spectrum.
Yes, so it's them verbally saying that, yes, I feel as though I'm ready, and they're confirming that because they're also informing you of what activities they're doing to enable that. So the concerns that we possibly would have in this case being that this person's got financial pressures, and actually they're very, very engaged in work. Work means an awful lot to them, which may very well push them to say, yes, I am ready. And so what, I'm still having 2-hour naps in the afternoon, and I can't really consistently get myself up out of bed. Anybody else got any other shares or comments on that?
I'd agree. I think the sleep one is massive at the moment, and this is what I'm hearing, from again a lot of patients who have had a lot of time off work. Their sleep, because we do activity diaries with them, their sleep is all over the place, over the place. And then, as Claire said, they'll suddenly say, I've got to get my sleep pattern back to normal, because otherwise I'm not going to be able to get up at 6:30 to get to work here. And it's like, okay. So it's when the talking and the behaviours start to match. I've also had a couple who've actually, put in dates. I want to be back to work before August. We have had to have a bit of reality check on some of these, but again, it's like, okay, well, great. At least you're thinking about it. That's really positive. Let's, what do we need to work on to make that more of a reality? But the sleep biggie. That's all over the place. Patients. Yeah.
I think the ones where they're maybe saying, I can go back, but you're thinking, how's this going to work? I sometimes say to them, if I said to you in 2 weeks' time you're going back to work, we can figure out so much, this is what you'll be doing, like, how do you think, how would that go? Like, how would that be managed? How do you feel? And some of them start almost getting quite panicky. They're like, I don't know, because I'm still sleeping 3 times a day. And I think sometimes it's giving them that visual that you just say in a scenario you were going back. So some of them are like, I can go back right now. Yeah, okay. Monday, I said you were going back on Monday. They then sort of go, or it can work both ways.
Yes, absolutely. Yeah. Anybody else? Any other comments on that? I'm totally with you with the sleep perspective as well, because especially with this sort of case where emotional flexibility in a teacher is so important. And of course, if that person is struggling with fatigue, then their ability to have that, to be flexible and to be emotionally managed and contextually appropriate is, of course, very much reduced. And of course, and in a classroom environment, they have to do rapid decision making as well. It's a busy place. So, if they're not getting that restorative sleep, and they're still feeling that they can't sort of survive the full day at home doing normal day-to-day tasks, then yes, there requires what Claire suggests there in terms of giving that picture of potentially what it means to return back into work.
I think as well, we're talking about people who maybe are pushing themselves too quickly, but it's also the other end, isn't it? It's the ones that you think actually they probably could be going back sooner. But there's, you know what it's like, you've been off work for a long time, your sleep does go out of sync, doesn't it? And they do start staying up really late, then they sleep in the mornings, and they have a little nap after lunch because they've got nothing, you know, that's what they're at home. So sometimes it's just sort of rebooting the daily pattern.
Yes, and getting some stimulation going in their day. So actually this fatigue is because you're bored, and actually not enough activity going on. And that's really hard. I mean, a lot of the people that I talk to, and I did a LinkedIn post about this morning, actually have very little going on in terms of life, good life out of work. So when I'm trying to ask them to build more into their day and return to what they would normally be doing, and I start talking about interests and hobbies, often there's not a lot of stuff there, which I find can be quite problematic as well.
I've also seen the flip side of that, of where they've had hobbies, but they felt so guilty in pursuing them because they might be sharing a house with somebody who is working, and they don't want that person to perceive that they're having a nice time, you know, whilst they're off work because they're playing the guitar, for example. So again, it's like talking to them, saying, well, one, set the expectations, have a chat with that person. But actually you could use this to your advantage. So if it was the guitar, you know, learn a new skill. So you are setting an aim or a goal, so it becomes more purposeful as opposed to I'm playing the guitar. But yeah, there has been a lot of guilt about, you know, them wanting to do something, but then actually not. But yeah, filling their day is really, really hard. I think that's one of the reasons why the sleep pattern, so they sleep really late into the day, so they don't actually have to do a full day. I've had somebody who has more chronic fatigue, that, you know, she wakes up really late in the day because the anxiety of being around people doing their normal to and fro and not being able to do that, she just can't handle. So rather stay up late, and then so it's really interesting.
It is very interesting, isn't it, what people do to manage the circumstances and where they're at and their emotional responses to the situation. So adjustments, what would you suggest to both the individual and also the employer? So we're thinking this person, okay, is ready to return back into work. So how is that going to be enabled? And what is the adjustment advice that you'd offer?
Well, I think he's been off work for 6 months, which is quite a long time living with long COVID. So adjusted hours is probably going to be needed, potentially depending on his commute and work tasks, potentially some working from home options. If he's head of year 8, he's probably got some overseeing work to do. And I think, like Colette said, having a look at the breakdown of the timetable. I think that would need quite a lot of consideration, just bearing in mind, like you said, the shortness of breath and trying to talk for too long, the demands of the D&T work as a teacher, and sort of acuity and the brain fog. So I think hours, sort of a phased return to work, adjusted hours, also adjusted duties, and I think it's the timetabling for someone at year 8.
Anybody else?
The other one, again, just thinking of the fatigue and brain fog, it can be triggered by emotional. So it could be that, say, for example, having attended as a parent, I know how full on staff parent evenings can be. So it might be even thinking ahead and saying, if they know there's a meeting which is going to be particularly emotionally draining, then to plan for the next day to be more of a rest, quiet day. So actually those kind of adjustments as well. So just having those agreements in place that this is a high stress or high emotional situation, then the next 2 days it should be a little bit less full on.
I think maybe, Colette, do you think with the fatigue and shortness of breath, maybe thinking about his positioning when he's doing his tasks? So when he's teaching, trying to remain him seated where possible, rather than prolonged standing and walking, just trying to any little adjustments. Sometimes it's available, but they're not used to doing it that way, but it might just be like a tweak to his position, getting short breath and fatigue.
And it's other things like there's usually technicians in DT departments, so can the technician come in, or is there an A-level student who they could pull in and say, hey, can you help me demonstrate this? So I think letting them explore those aspects as well. I imagine somebody's been covering the head of year job. So is there a job share situation there, or at least a return to work job share? I agree, Claire. I think definitely looking at how they're positioned and just trying to make it as easy as possible, isn't it, really?
I think this goes right back to the first job analysis questions that we were asking, and trying to extract from them that their perception of what they feel would be difficult. And now we're at the stage where we've got that information, but we're at the stage now where we've got our own clinical judgment on it. So bringing those two together, the employee perception and our professional judgment, and then I try and encourage a lot of planning work before actually returning back into work, especially with this type of role where it's a massive role with a lot of stuff in there. So writing down the elements, so the individual employee and the line manager, write that down, and write down what are the high, medium, low demand areas. And I stress that what we're trying to avoid is a boom bust scenario, which, with long COVID, it's very difficult to be sure that they are substantially recovered and they're not going to have, a relapse of symptoms. So we always need to bear that in mind to avoid the boom bust. And I put in there about effective rest and telling them effective rest is different from just sitting down and continuing to scroll, or you think you're just doing some easy marking. No, effective rest is disconnecting from anything at all. I've got other stuff like, in these scenarios as well, where somebody's using their voice a lot, I've recommended voice amplifiers. As well, because of the shortness of breath, so trying to reduce down that respiratory demand. And it's exactly like you say, Colette, as well, looking at that bigger, wider picture of it. It might just be the occasional parent evenings, but they're hugely demanding. So having that recovery time afterwards. And what do people think about, and what are they doing in terms of encouraging ongoing line manager sort of well-being reviews? What sort of frequency and content do you suggest with regards to those?
I think with someone like this, I'd probably have a very regular contact with the line manager. Usually I say kind of, within the first couple of weeks, and then on a monthly, depends on the case, really, sort of MSK case. But I think someone like this, who's been off 6 months, is going to have probably a phased return to work, quite adjusted working role. I'd probably almost say weekly, but with an opportunity to have, a daily catch up if needed. Just, you kind of want them to be transparent, open and honest with their managers, don't you? And if they are struggling, rather than get into the boom bust, they need to sort of be able to voice that sooner rather than just struggle on.
Brilliant. Yeah, I love that, the check-ins as well as the more sort of formal and structured reviews. Yeah.
What we're also seeing with long COVID, this is possibly more anecdotal than anything else, is that it's this accumulative effect. So they're okay, and then suddenly, boom, 3 or 4 months in, even 6 months in, it all just falls apart again. So I completely agree with what Claire's saying. It is that, more often than not, but also just for them to keep on checking in on themselves as well. Do I still feel enough energy, or are there everything's building up? But it's been really difficult to second guess, what's going to cause it. But we are seeing this a bit, that they're fine, and then suddenly it just goes again. So it is just checking in all the time, and just really baby steps when they're increasing the work demands. Yes.
And have you had any pushback from employers sort of saying, we can't sustain this and we need predictability and consistency?
That's the biggie, isn't it? And I think it's very dependent on who your employer is.
Yes.
It's really difficult. And I don't know whether it was in Somme or somewhere else, they particularly like the Equality Act, is long COVID going to be part of that? We're coming up to a year now, but I think it's just going to be so hard, and it must be so hard for HR managers to say, no, I'm going to go completely against policy and rewrite this. It's really it's really challenging, really.
It is, and people haven't recovered within that 12-week period, then the Equality Act and disability criteria, is likely to apply, isn't it? So it is extremely difficult, and some of my really small employers, we've just got to let them go. We can't continue. Anyway, advice to the employee and signposting. Well, Claire, if they're in your service, they're really lucky, aren't they?
Colette's got an amazing booklet as well. She doesn't like to talk about it, but she's put together this awesome booklet that's like signposts them all over the place and has lots of tips and
fantastic
stuff.
It's not a booklet, it's a tome. It's
like a novel.
Brilliant.
It's all electronic, so it doesn't look so bad. But thank you, Claire, it's very kind. Because there's things which we won't be able to help them with. And also, I suppose what was in the back of my mind is they may develop this symptom 3 months down the line when they're with us or just leaving us or something else. And at least they've got something which can go, wait a minute, I know there's a web link or something I can read which might explain it. But
yes, absolutely. So I'm moving the slides on because I've got a slide about so these are kind of some of the places, not all of the places, but some of the places that I signpost to. I'll tell you actually, so I am having cases where they're telling me the GP, they'll say all I've done is have a telephone assessment with a GP. They're not having those face-to-face assessments. They're not having, the nice guidelines and what's detailed in their recommended. So I've actually had to, write out the specifics of that and give it to the employee to be able to say to the GP, actually, the nice guideline says this and what I should be doing, which is, really quite worrying. So I do flag up to my employees that there are these national guidelines that clinicians should be using. The Your COVID Recovery, I think, is fantastic, resource and tool. And we know, Colette, don't we, at some point it's going to be developed further, but the complexities and politics associated with it is, well, you can imagine. Yes, and the post-COVID hub, I guess the Asthma UK and British Lung Foundation work, and Royal College of Occupational Therapists. They've done some great work looking at management of fatigue. And just for general learning as well, I point out that, these are medical kind of YouTubes, but don't be put off by that, because actually they're quite accessible. They're not particularly technical. And I think as well, in my assessment I've done as well, is that it's about validation. A lot of people have really struggled to get recognition for it. Okay.
Yeah, Anna, just because that's quite interesting. I'm seeing this more and more, is that, we're seeing people for long COVID rehab. So they've already gone through, a case manager or OCALF or something. And yet the patient is still coming to me saying, oh, I've definitely been diagnosed with long COVID. And I'm like, sorry, I thought we established this ages ago. And oh yeah, the physician definitely says I have this. And I'm wondering, who's putting this doubt in their mind? I don't know whether it's the GP, I don't know whether it's them trying to, I don't really have this, because I think that's going to become more and more problematic of, I don't have a diagnosis of long COVID, particularly when we do that HR, return. Are you seeing that as well, or?
Yes. And I've been having a look at the long COVID Facebook groups and reading the information. I'm quite connected on Twitter as well with long COVID. And that is such a strong theme, that people are getting messages from all over. So messages from clinicians, messages in society, that long COVID doesn't exist, or they don't have long COVID, or the latest one that I saw was, it's because people have been through enforced lockdown that they are experiencing these symptoms. There's all sorts of stuff, and out in social media land, that these messages, people are picking up these messages. And you think, okay, so that's going to be probably within their closer circle as well, family and friends. Okay, so that's all that I had, and we're up at 3 o'clock. You're on mute.
Oh, sorry, I have to go to a patient now, but thank you so much.
Pleasure. Love you all. It's been great. Thank you, everybody, for your contributions.
Thanks,
I've
Anna.
learned loads. Okay, then. Bye, everyone.
Thanks so much.
Bye.